Healthcare policies are shaping every moment of care across the continuum. Legislative decisions directly impact how clinicians work and how patients receive care, which is why it is not enough for clinicians to sit on the sidelines. We have to actually get in the game. We need our voices in advocacy, shaping the very future of healthcare from both the bedside and the ballot. Are you ready for it? Welcome to Healthcare Disrupted. The lines between legislation and delivering care sometimes get blurred. But in reality, everything happens at the bedside is connected back to policy and regulation in some way. Adding bureaucracy doesn't necessarily help the patient, especially when no clinical voices help build it. Government may approach decision-making with good intentions, but sometimes there's a disconnect between what their intentions are and what happens at the point of care. I have Michael Richards with me today. He serves as our System Vice President of Government Affairs and Public Policy at SSM Health. He's going to help us break all of this down. Michael, welcome to Healthcare Disrupted.
Thank you very much, Amy. I appreciate it, and I appreciate your leadership and being able to share the voice of government affairs because healthcare is so complicated.
So, Michael, you have a really diverse background. So tell us a little bit about yourself and your background and really how you got to where you are today in this role.
Well, thank you. So I've been in this role for in government affairs for about 25 years. I started off working in the state government in Wisconsin and really learned about how the sausage making process works in government. And then I took a detour and I ran the government affairs at Harley-Davidson Motor Company for a few years. I tell people now I shave and wear sleeves to work, but I really got into healthcare when my father got sick. He was always the rock in our family and had a tick-borne illness that got around the sack of his heart. And the job was posted the day back in Wisconsin at a system called Gunderson Health System and really took off and got engaged in healthcare and really liked it. And then at that point in time, SSM opportunity came here, and I came to SSM and have enjoyed every single part of it, especially the mission, the vision, and the values of the organization.
That's great. And we're so glad you're here, Michael. You bring such a wealth of knowledge and information. And so we talked a little bit at the beginning of the show about how everything is tied back to policy in some way. So I think about delivery and access. I think about how it impacts our patients, our workforce, payment model, quality outcomes, and even now transparency. So that's a lot when you think about that. And I think sometimes we take it for granted, especially those of us who are delivering healthcare. So as you think about regulation and policy making and how it's impacting healthcare today, how would you sum it up for us?
Well, healthcare is probably the most regulated industry out there today. It's probably akin to banking. And so you think about not only the patient care setting side, but you also think about the business side of the organization. And so when you put those two together, I tell people a lot of times, in government affairs and advocacy, we deal with intersection improvements at a new hospital to make sure patients can get in all the way to Medicare reimbursement and everything in between. So we are jacks of all trades, masters of few, and it really is a difficult thing for people to get their arms around of the amount of regulation, the amount of impact it has on healthcare. So, for example, one of the big items that we deal with is reimbursement, right? You need to make sure that you're getting paid for the services that you provide. Otherwise, you're not able to provide those services. You're hearing a lot about that today in rural healthcare where their reimbursement isn't matching being able to keep their doors open. But all the way over to making sure our nurses and clinicians have licensure in each state and ensuring that they can get a license within a reasonable time to provide that care and provide that access. So again, advocacy is it can change from day to day. The themes stay the same, but it's pretty daunting.
So you've used the term advocacy a couple of different times, and we're often called to participate in advocacy as clinicians. What does advocacy mean to you?
So advocacy means to me is if we all speak with a different voice, it kind of will get lost in the woods in Congress, in the halls of Congress, or in the state houses. So advocacy for me is basically having a singular message on each issue that we can take to our lawmakers to, I guess, speak on behalf of our patients who maybe don't have that voice, speaking on behalf of our communities, and advocating for the services that we need to provide there, but then also advocating for our providers and our organization as a whole, so that our lawmakers, our regulators understand the pressing needs that we have, and also providing them solutions on how to make it better. I don't always want to go and say, no, we can't do this. At SSM, I'd like to say yes, but here are some options to make it better, if that makes sense.
It does. And I think what you said is really beautiful, and it gets lost sometimes. But advocacy is really about our patients and their families first, thinking about what's best for our communities, and then thinking about what's best for our clinicians as well. And so really keeping those three different segments of the population really at the center of everything that we do. So thank you for that. So we still have the most expensive healthcare system in the world. Yet we're doing all of this good work. We're trying really hard. We're making some difference, maybe not making as much difference as we could. What are really the results of these investments, and why aren't we seeing change and impact at the magnitude we really expect?
You're right. We do spend a lot on healthcare in America. In fact, our CEO, Laura Kaiser, and I have had conversations with lawmakers and said, we believe that there's enough money in the global spend on healthcare, but the distribution of that money doesn't necessarily match where it needs to go. So, for example, at the federal level, social services funding, whether it's Social Security, Medicare, Medicaid, food service, food SNAP, the SNAP programs, those account for the majority of our overall spend at the federal level. And yet, are we getting the outcomes we need? And the problem I see is we all like Legos. Legos are a great thing for kids. Some adults like Legos too. You buy a box, you put the box together, it looks perfect, okay? And that's what it would be nice for healthcare to look like, is whatever that design should look like. But what our healthcare system looks a lot like is crumpling up all those Legos, throwing them in with the other sets, and trying to go back and rebuild it. It just doesn't look the same as it should. And I think lawmakers try to make good intentions. You said that at the outset of not all the right people are at the table when they're making these decisions. So we sometimes will support one service, whether it's the pharmaceutical industry or the managed care organizations. Sometimes it's the healthcare organizations. It's not in thinking of the whole organization when they think about policy. So there's winners, there's losers, and oftentimes healthcare turns into a jumbled mess of a bad Lego set.
Yeah, I think that was a really good description. And we've talked a lot on the podcast about complexity and the complexity of healthcare. And what I hear you describing right now is how that complexity also plays out when we're thinking about regulation. And maybe we're thinking through very siloed pieces instead of what the impact is on all of the downstream or the end-to-end journey in healthcare. So as we think about that and we start to think about and represent all the complexity in healthcare, there's this shift in mindset that's happening, in our regulation and then across the industry, from this fee-for-service to this value-based care mindset. So how is regulation going to impact that? And what's our position as we think about advocacy in this area?
That's a great question. I think at the core, when you think about healthcare policy and reimbursement, it always comes back to the funding. I mean, that unfortunately that drives everything, but we have to pay attention to it. So government has a major deficit right now. They have a huge national debt that we have, and I think there's a lot of pressures on them to solve that crisis. Unfortunately, we get caught in the middle of that. So over the years, there's been a drive towards value-based care, right? So in a general sense, cost and quality. You want to drive down the cost of care. You want to increase the quality. So in my past life, I ran a group called the Healthcare Quality Coalition. And that was 10 years ago when value was just starting to take on. We haven't gotten there as a system yet to get to value-based care because the chassis that we're built on is fee-for-service. And the incentives are not at the front end for health systems to build those value-based systems, whether it's getting more involved in the community to prevent some of those more high costly, care delivery services that we might provide. And so the incentives are not there for us to get to value as a healthcare industry as they should be. So it makes fee-for-service still kind of the king in terms of the reimbursement structure. So I feel like we need to think differently from not only a regulatory standpoint but also a healthcare delivery standpoint to get to value quicker. So to answer your point before is what's going to happen. In the past, they would give us some sort of carrots to get to value-based care. Now, because of the budget deficits and debt that we have, I think it's going to be you're going to get to this value-based care, and if you don't, then you're going to be reduced. So the pressure is going to be on from a financial standpoint. And our position is we certainly would like to take on more value-based care, but you need to give us the flexibility from a regulatory standpoint, but also some of the money to kind of get those programs up and running.
Yeah, so it sounds like you're saying we should not let a good crisis go to waste.
That's right. That's right.
Really use it as an opportunity for change.
Absolutely.
So you talked a little bit about all the pressures that are happening, the deficit in the budget, how that's playing out then in some of the regulation, and then how that rolls down to those of us who are delivering healthcare. So for our listeners who are not in healthcare, how would you describe the external pressures that we're facing today?
I would say they're significant, and I think the mindset in our culture is changing. Probably when I first got into healthcare 15 years ago, we focused around kind of the health homes, right? Wrapping around care, getting people engaged in their healthcare, which was important. But we've shifted now to consumerism, right? So how much does everything cost? I want to shop around. I want price transparency. Not necessarily a bad thing, but I think that's a pressure on us. So when people talk about price transparency and they talk about consumerism, there's a lot of added burden onto us to more administrative burden for us to compete in that marketplace. And so I think that's difficult for us. I also think that we're getting sicker as a country. We also have an aging population that's going to need more care. So with all the pressures of reduced reimbursement, we have people who want to shop around more for services and they want more information, and yet we're getting paid less for the services that we provide. That creates kind of a I wouldn't say a crisis, but pretty close to a crisis in healthcare for us, and that's going to continue to be a struggle.
And you talk about transparency, and that's really complicated in healthcare.
It is. Because
the patient's not paying for the service. We talk a little bit about what that really means when you think about price transparency and how that's going to play out in healthcare.
Right. So when I speak to a lot of lawmakers and staff, they'll always tell me I can go in and I can get my muffler fixed on my car. I can go shop around online, and I know exactly how much that is going to cost me. But healthcare is different, right? So somebody walks into our door, they might have, one insurance, another person has a different insurance. They have a different deductible. They have a different copay. The service that I provide you might be a little bit different than the service I provide to the next patient. I think it's well intended to have transparency, but it gets to be difficult. And the business community pays for part of it, through private insurance. The government pays for part of it through Medicaid and Medicare, and then the patient will pay some of it. So when there's a lot of different payers in the mix, a lot of people on the hook, it creates a little bit more of who should be accountable for this and who should have more information on the cost and quality of healthcare.
Right, that's such a good example. I appreciate you explaining that to us. So as we think about everything that you've been laying out for us today, it is complicated and there is a lot of complexity. So how do you think about how are we using policy to care for our patients and caregivers?
Absolutely. So from an internal standpoint, my team meets with a lot of members of the organization. We try to understand, what is your vision? What is your strategic goals for the patient, to protect the caregivers, and also just to make sure that we're providing the best quality of service. So when we get that, my department probably touches more departments internally than any other department. And so we try to gather that in, and then we really try to understand what does the political environment look like? What is possible for us? And then we try to go after that angle. And so we meet with lawmakers, whether it's at the local county level, city level, all the way to our state levels. We meet a lot with our Medicaid departments, and then we meet at the national level to try to tell our voice. I'm a big proponent of coalitions. Because we are a regional health system, and we need to make sure that we have a louder voice nationally. So, for example, I created this group called the Interstate Healthcare Collaborative, where we have been focused on interstate license compacts and telehealth policy. And when we have a louder voice as a larger group, then people will listen to us even more. And I think that that's a way for us to kind of steer public policy in the direction that we want.
That's great. You've given us some examples about reimbursement and how regulation impacts how we're paid. We've talked about access and how that impacts access. We've talked a little bit about patients and the impact on patients and community. And one of the things that we haven't talked about so far is quality and how all of our regulations impact quality. Will you share a little bit about that with me?
Right. If you look at the amount of quality measures that a hospital has, and I'm not a clinician, so I'm not dealing with this every single day, but I do hear a lot from my peers internally about the quality measures. I feel like a lot of times government will put into place quality measures because it's not like it's not important, but it's almost the flavor of the day, right? And we need to have measures that matter, right? So clinicians are working day to day, they're inputting their information in charts. We need to make sure that these measures match what true outcomes should look like. And then you also have the private insurance also has their own measures. So we may have different measures. For example, the state of Illinois has a different sepsis measure than we have in the state of Missouri. And we're seeing patients come back and forth, and then we have to choose which measure we don't want to get paid for. And that creates a lot of tension internally. And that's just one example of many. And so I think it's important for us to think about what's the most important measure. Is it a tactical measure of how many people, get screened, or is it an outcomes measure of whether or not the patient lives or dies, which is kind of an important measure, right? So I think we need to marry those quality measures up with what's reasonable for us to accomplish and what does not create an administrative burden and what's just noise in the system. And so our goal is to try to do as best as we can to educate people on what we feel matters.
Yeah, and really advocating for one data set
right.
across all payers, anyone who is interested in what the quality outcomes are, even making them publicly reported.
And that goes back to your transparency discussion too,
Yes.
right? But the problem with a lot of the quality measures is there's such a lag time to get them
Correct.
reported. So, businesses may be when they're looking at insurance, may look in the past and say, well, this is your quality measure, but they don't recognize in the 3 years that we had that measure, all the improvement that we did to get to even better numbers.
Right.
So it's the quickness of the quality data reporting, but also doesn't matter.
Yeah, and absolutely. I love your example of the sepsis criteria and sepsis outcomes and being different from one payer to another across our government payers. And so really all of our clinicians helping to advocate and you helping to lead us in that advocate voice around how we get to one data set so that one, we really are measuring what matters most, and we're able to delineate our quality and really stand firm in our outcomes and our results, but also decreasing that administrative burden. We talked about the cost in healthcare,
Yes.
and part of that cost sometimes is related to all the variation that you're referencing now, and the administrative costs that really the healthcare systems are putting out in order to deal with that administrative burden.
I agree.
So, Michael, you've given us a lot of valuable examples, and some of those are around the reimbursement pieces, and we've also just talked about quality and quality outcomes. And I think sometimes what's frustrating for a clinician is, how do you keep up with all the variation that is happening across the different payers? You utilize the sepsis example, and one set of documentation criteria is required for one payer, another set for a different payer. If you don't get it exactly right, you don't get reimbursed, you don't get paid, which then just compounds how difficult it is to make sure that we do what we want to do here at SSM Health, which is really care for all. And so as you think about that frustration, I know you hear it from clinicians all the time. What's your advice to clinicians related to that?
Well, I think it's making sure they're aware of what's happening in their sectors, right? So everybody has their own association that is giving a lot of good information that trickles down from their association. So I would say being engaged with their association from their specific, clinical group. And then also internally, we're trying to build out more education, more information of what is this rule that's coming down and how is this going to impact us? And then getting that information to where it needs to be across the organization. So there's multiple different pieces that a clinician can take advantage of. But again, I know that time is not something that grows on trees for a lot of clinicians. So trying to make sure that you, like I said, go to your associations and listen to some of the operational kind of communication that may come down.
So one of the things that I really appreciate about you and the team is that y'all do a wonderful job providing us a summary and a synopsis every week of kind of what's going on across policy and regulation, what our different lawmakers are thinking about, what we need to be thoughtful of, where we need to help shape. It's a lot of information, though, and it's a lot to keep up with, as you said, for your practicing clinicians. So, and it's hard to know now without somebody like you. It's hard to know what's accurate, what's real. And so where would you encourage our clinicians to get accurate and timely and effective information so that they understand what's happening across our legislation?
That's a great question, because there's a lot of information out there and you can get lost in it, and you can and I always think like it's trust but verify the information. So I think the best source of truth for folks is, one, ask internally. If there's questions, they can come to people like me or the regulatory affairs group to kind of understand, what it means to them, and then their association, right? So in nothing against associations, sometimes we disagree at SSM with some associations. So verify that with us, but usually they're very good at providing timely information that's more specific to their care practice. And then, if you're just watching the news, again, go back and verify it, because there's a lot of information out there. Everybody has a little bit of a bias, so you got to make sure that what you're hearing is applicable to your work.
So that's great advice, and really important for all of us as clinicians and healthcare leaders to make sure we're staying informed and well informed, and that we're understanding and being respectful of different viewpoints. So how can clinicians play a role in shaping this policy? So we've got to understand, but once we start to understand, how do we play a role in shaping policy, and how can we make sure that the clinicians' voices are heard and are at the table when some of this policy is being designed?
Oh, that's great. So I think one of the key pieces is what you talked about in your last question, was just being educated, right? So one, understanding what's happening in the world around you. I think that's important to kind of get the full picture, right? You talked a lot about some of the getting engaged in associations and groups. So a lot of our providers are members of an association, whether it's a nursing association or their specific academies that they're part of. And then if they want to get more involved after not just reading the information and getting involved, but sitting on work groups. So you're not going to get a board seat until you kind of put in some of the work. Sit in on the work groups, give your perspective, share some of your experiences with them. And that doesn't need to be necessary at the local level. It can also be at the state level and even at the regional chapter level. I think you just dip your toe in there a little bit, see what interests you, and then take advantage of that. And then I always think that all politics is local. So don't be afraid to get involved at the local level and volunteer and be part of your church, your community, your school, because a lot of things that impact us every day are just in the world right around us. So if you can prove that, then we can start to work to improve and advocate at a higher level.
That's great. So really just being a good citizen.
Just being a good citizen and in being engaged. I know it takes time for people out of their lives. I get that. But I think it's also, if you want to make a change, you have to be able to make that investment of time, resources, and talent and expertise. From an internal standpoint, if there are issues that are coming up, I encourage people to kind of bring that up through the channels in the organization. Because if you see something that doesn't make sense, or you have an innovative approach, let's go through that process internally, and then we can raise that up a little higher.
So, Michael, as we think about all of those who help us provide healthcare, all of those who receive healthcare, there's so much going on. You spend a lot of time on the Hill. What do you see that's coming that we should be thoughtful about and that we should be thinking about as we start to plan for the future?
So in the immediate environment, we just passed a significant HR 1 bill that's going to make some changes to the Medicaid program. That has a 10-year kind of a window of implementation. So we're going to continue to see some more reductions on the reimbursement side and eligibility, right? So we're going to be asking a lot of our nonprofit partners to help us get people enrolled in healthcare. That's going to be important for us. But what am I hearing outside of that? I think you're going to continue to hear more on the consumerism. You're hearing a lot more on the AI, and that AI is going to solve all our problems. I don't think we're there yet as a healthcare industry that AI is going to solve our problems. We're still going to need people at the bedside to provide care and quality services to our patients. And I don't want us to kind of lose sight of the access to care component. So when we think about the financial implications of the country today, the rural health care, the access to care, we hear a lot about access to behavioral health services. Coming out of COVID, I think that continues to be a bipartisan support is behavioral health care and trying to make sure that there's enough services there. And then, as you and I have talked about before many times, is workforce. I think there's a realization that we have a workforce crisis. I've been in public policy for over 25 years. It seems like we've always talked about the workforce crisis, but I think we're getting to the point where they're actually going to try to work to make something happen there. Like I said, I don't think AI is going to solve all those problems. Nor should it. But I do think that we need to think about how do we reframe healthcare in a way that is exciting for young people to get involved in. It's a calling and it does great things for our community. So to circle back, I would say behavioral health is a big issue. Reimbursement is going to be a big issue, and the consumerism angle is going to be a big issue. For us. And I think we at SSM are well positioned to provide thoughtful responses and policies, but it's going to be a challenge across the industry.
Yeah, so to boil that down, you're really talking about access and workforce and how those two intersect with each other. And access being big access to behavioral health care, yes. Access in rural health care, and how do we have enough access? And if we don't figure access and workforce out, that could honestly be the perfect storm for us.
I agree, and we're trying to work very closely with a lot of our states and the kind of the portability of licensure, especially where a patient is in one state, providers in another. You need to make sure that you're licensed in that state for telehealth services. But even for us as a border community, right? How do we get nurses into Illinois without having to wait 6 to 7 months, or doctors to get 6 or 8 or 9 months to get licensed in certain states? We need to make it easier to get licensed. We need to make it easier for kids to find the pathway into healthcare. What we've done at SSM with FlexPath and tuition reimbursement and the programs that we have, I think are very innovative, and a lot of lawmakers really like to hear about what we're doing. Because a lot of times they'll hear, well, we've got workforce challenges, and I can go in and say, yeah, we do have workforce challenges, but this is what we're doing to address that. And, then people's ears perk up and they say, this is great. How many other people do things like this? And so it's good to be an innovator and going in and sharing the successes that we have, but then also letting them know that that is only one piece of the pie. We still have more of the pie that we have to overcome, not just for the existing workforce shortages, for example, but also for the future. Right. So in advocacy, it can't just be a short-term solution to things. We also have to think about the long term of how are the policies we do today going to impact us 10 years down the road.
So, Michael, what you're really sharing is there's a lot of uncertainty that's coming. I think one of the things that is a bright spot in healthcare in particular is all of the highly talented, highly educated, compassionate people that are serving and delivering healthcare every day. And so as we think about what our opportunity is, it really is about getting all of those diverse voices and perspectives to the table to help shape the policy that we want in the future. And we have that opportunity now, is what I hear you telling me.
Yes, absolutely. And so this last year, we provided a very detailed memo to CMS as they were thinking about how do you make the regulatory environment less burdensome for providers and for providing access to care. And so Laura Kaiser was able to sit down with CMS and have a detailed conversation about some of those items. So they're listening, and we're seeing some movement on the regulatory side. We also are seeing some on just kind of on some of the food initiatives. We have the administration hasn't provided a lot of detail yet of what that may look like, but I think there might be more of a push towards upstream, healthier communities, healthier food systems. And so as we think about that, we're trying to provide them more solutions and not just being reactive to the system, to whatever may come out of Washington, D.C.
Absolutely. We all have to be the change we want to see.
Absolutely.
So as we think about wrapping up today, I always love to leave the audience with a call to action. So what do you think as we think about our clinicians and healthcare leader? What is our call to action? How do we make a difference?
Well, first of all, they make a difference every day with the care. Having family members who are patients. I don't think lawmakers always see the impact on a day-to-day basis because they're not always patients. Seeing people on their best days when a child is born to the worst day when somebody close to them passes. So they are doing a lot of work, but I think the call to action would be to get involved, get educated, understand the full context of what's happening in the political process, and sharing their voice, and not just sharing their voice of no, we shouldn't do this, or yes, we should do this, but how can we make it better? How can we make the system better under the current kind of environment that we're in today? And thinking long term about if we make this change over here, how does this impact my coworkers over here? So I think just being involved, being engaged, being educated is the most important part, and keep doing what they're doing of providing high quality care to our patients and community.
Thank you, Michael. That was beautiful. Thank you for being with us today, and thank you for all you do for our patients, our communities, and for our caregivers.
Thank you for your leadership.
Thank you so much for joining me on this episode of Healthcare Disrupted. We want to hear your voice, so dive into the conversation with us, challenge us, and help us disrupt healthcare for the better. Like this episode, subscribe now, and wherever you get your podcast, follow us on this journey.